Hi, this is Dr. Dow here from Phoenix Children's Hospital, and here I'm going to present an unusual presentation of extraosseous Ewing sarcoma in a 3-month-old male presenting as a bump on the head. We have no disclosures. Now, extraosseous Ewing sarcoma arising in the head and neck region is extremely rare and even more rare in the neonatal period. We present a case of extraosseous Ewing sarcoma involving the right eyelid in a 3-month-old male. Ewing sarcoma was initially described by Dr. James Ewing in 1921. The Ewing sarcoma family of tumors includes Ewing sarcoma of bone, primitive neuroectodermal tumor, otherwise known as PNET, and thoracopulmonary PNET, otherwise known as Askin tumor. Extraosseous Ewing sarcoma is rare when compared to Ewing sarcoma of the bone, with prevalence of 15 to 20% compared to that of Ewing sarcoma of the bone. It is usually seen in young patients, with 85% of cases seen between 2 months and 30 years of age, but has been reported to have an age range of 1 month to 81 years. Like Ewing sarcoma of the bone, extraosseous Ewing sarcoma is rare in the Asian and African population. Common sites of involvement include the paravertebral region, lower extremities, head and neck, and pelvis. A 3-month-old Native American male presented to the emergency department with a slow-growing lesion on his forehead, not present at birth. The patient's mother noticed a small flesh-colored lesion at approximately 2 weeks of age that had been increasing in size. There was no discoloration. The patient had been followed by his primary care provider, who recommended warm compresses. However, there was continued right forehead eyelid swelling, and the patient was referred to ophthalmology due to concern for visual impairment. Physical exam was significant for a firm, lobulated, flesh-colored, golf ball-sized mass over the right forehead without discoloration. An MRI of the brain with and without contrast was performed and demonstrated a 4 cm enhancing medial right preseptal mass initially thought to represent hemangioma. Dermatology was then consulted and the patient was treated with propranolol and prednisolone taper without appropriate clinical response. Surgery was then consulted for excisional biopsy, which revealed Ewing sarcoma with positive margins. Metastatic workup was negative. Radiation therapy was offered but was ultimately declined by the patient's mother. Here we have an axial T2 weighted MRI image of the brain demonstrating a circumscribed lobulated mass in the right frontal region extending to the medial pre- and postseptal spaces, demonstrating heterogeneous T2 signal. On the left is a DWI image and on the right is an ADC map demonstrating diffusion restriction. On the left is a T1 weighted pre-contrast MRI image of the brain. On the right, post-contrast image demonstrating avid enhancement of the right frontal lobulated well-circumscribed mass. Here we see it again on this T1 weighted post-contrasted sagittal image of the brain demonstrating avid enhancement. Here are the histological slides from the biopsy specimen. Figures A, B, and C are hematoxylin and eosin stained slides. They demonstrate sheets of solid tumor arranged in nests comprised of monomorphic small round blue cells. As you can see, there is high nuclear to cytoplasmic ratio with fine chromatin pattern and focal cytoplasmic clearing. Figure E is CD99 stain, and tumor cells demonstrate immunoreactivity to CD99, which is a marker for Ewing sarcoma. Imaging features of extraosseous Ewing sarcoma are nonspecific. Plain radiography can demonstrate a soft tissue mass in about 50% of cases, sometimes with periosteal reaction, erosions, cortical thickening, or even osseous invasion. Calcifications can sometimes be seen. Nuclear medicine studies can demonstrate increased radionuclide uptake, and FDG PET can be used to evaluate primary lesion as well as metastasis. Ultrasound can demonstrate a hypoechoic vascular soft tissue mass. CT can show a nonspecific soft tissue mass with similar attenuation to that of muscle. Areas of low attenuation may indicate necrosis or hemorrhage, and adjacent osseous changes and calcifications can also be seen on CT. MRI imaging is useful for tumor staging and evaluation of involvement of surrounding structures. MRI features are also nonspecific and can demonstrate heterogeneous soft tissue mass with intermediate T1 signal as well as intermediate to high T2 signal. Contrasted studies can demonstrate heterogeneous but prominent enhancement, and although not unique to extraosseous Ewing sarcoma, the presence of high-flow vascular channels, as demonstrated by serpentine low signal intensities, should raise the possibility of extraosseous Ewing sarcoma in a young patient, as in our case. A pseudocapsule can sometimes be seen. FDG PET and MRI are vital in evaluating tumor response to treatment, recurrence, or metastatic disease. The differential diagnosis includes rhabdomyosarcoma, higher grade vascular lesions like caposiform hemangioendothelioma, hemangioparasitoma, or angiosarcoma, and of course lymphoma. Successful treatment involves a multidisciplinary approach. Initial therapy includes neoadjuvant chemotherapy for eliminating micrometastases. Primary tumor reduction involves surgical resection, radiation therapy, or both, and aggressive therapies have led to overall 5-year survival rates of 82% in patients with localized disease to 39% in patients with metastatic disease at clinical presentation. Extraosseus Ewing sarcoma is a rare entity in the neonatal population and should be included in the differential diagnosis of head and neck soft tissue masses despite the patient age. These are references. Links will be provided in the description below. And thank you for watching, and please subscribe.